background noise, and hopefully my dogs will behave today. All right, we have a good bit on here. All right, you guys, if you want to unmute yourselves for just a minute. All right, couple questions to just kind of review on diabetes. So whether you have type 1 or type 2, kind of what's your ultimate goal when you have a patient with diabetes?
To manage it.
Manage it, absolutely. And if you're managing it well, then you're preventing further what?
Hypoglycemia.
Problems.
Complications.
Yes, complications. So, in one of those could be hypoglycemia too, but yes, the complications. So when you have the long-term hyperglycemia, that's when you run into the problems with the micro and macrovascular complications, potential for diabetic ketoacidosis, and so all of those complications that you're looking for. So what are the 3 aspects that you're going to come at to treat and teach your diabetic patients?
Diet, exercise, medications.
Very good. So if you have a patient, so let's say they're a type 1 diabetic, they're very athletic, they go for, whether it's their sport practice, whether it's a run, what are you going to encourage them to do? What's going to be included in that education for them?
To check their blood sugar before and after the exercise.
Eat before, during, and after exercise.
Very good. All of those. They can check their blood sugar, and then make sure they're taking some kind of snack. What kind of snack would you recommend they take?
Simple sugar.
Simple sugar, if you're super low, what would last a little bit longer than a simple sugar?
Protein.
Some protein, right. And then what about patients when they're sick? They wake up and they're just not feeling well for that day. What are you going to encourage them to do?
To still take their regimen.
Yes, still take their medicine, still check their blood sugar, continue to do everything as best as they can. With your oral anti-diabetic medications, what's your biggest side effect?
Hypoglycemia.
Yes, hypoglycemia. And then what, let's say this is a young 21-ish year old who enjoys the party scene. What are you going to caution them to be careful with?
Alcohol.
Drinking.
Yes, so the alcohol, be careful with that. So if you have a patient whose A1C is 11, is that a patient who has managed their diabetes well or not?
Has not managed it well.
No. What do you want that A1C to be?
6.7.
Below 7.
Yep, 6, 7, lower. Yeah, the lower the better. Yep, in that range. Let's see. What are you going to teach them about their foot care?
To check their foot daily.
Don't use hot water. Don't clip toenails.
All of those
Don't
are
go
correct.
barefoot.
Don't go barefoot.
What type of shoes should they should wear shoes, and then well-fitting shoes. So you want to be sure they're not rubbing blisters on their feet or that they're too tight and compressing their feet. What about the kidneys? What's a sign that the kidneys are not as healthy as what they should be?
Ketones and
Ketones and albumin.
Yes, ketones and or albumin in their urine. If you start seeing those, that should alert you that you want to look at the additional kidney labs and start looking to see how their kidneys are functioning. What are your kind of 3 main symptoms of hyperglycemia? Yep, your 3 polys: polyuria, polydipsy, polyphagia. Are you going to have weight gain or weight loss?
Weight gain.
loss. Weight gain.
Weight loss.
Is it weight loss or weight gain? Weight loss, right?
Typically weight loss, yes. And then what's a medication that can cause hyperglycemia?
Steroids.
Steroids, correct. There's several others, but steroids is definitely the biggest one that the most common. What are some things you'll watch out for with gestational diabetes?
The mother and the baby, like the baby's weight.
Very good. What kind of medication will that mom be on who's been diagnosed with gestational diabetes?
Insulin.
Insulin, not your orals, correct. Okay, so you have a patient, a type 1 diabetic who's been sick, hasn't managed everything very well. They end up with a high blood sugar, like around that 600 range. They have that fruity breath. What fluid replacement what are you going to suspect, and what fluid replacement would you start with?
DKA, start with IV normal saline.
Diabetic ketoacidosis and normal saline, correct. And why do they have that fruity breath?
The acetones are being exhaled.
Right, so they're trying to compensate for it, correct. So what's their blood pressure going to be, high or low?
Low.
Low, because if you're needing to give fluid replacement, they're going to be dehydrated and they're going to be hypotensive. And then which electrolyte imbalances are you going to anticipate?
Low potassium.
Potassium.
Say that one more time.
Low potassium.
Potassium.
Yes, low potassium.
Sorry.
And then say the blood sugar, you've given fluids, blood sugar still is high. What else are you going to anticipate for treatment?
Insulin bolus.
Insulin bolus.
Yes, insulin, and then maybe leading to an insulin drip. And so again, these patients are very sick. Most likely these are straight up to the ICU type patients. So you have your hyperosmolar hyperglycemic state, your HHS patients. These are very similar, but these patients are your type 2 because they have a little bit of insulin on board. So they're not quite as acidotic. All the other symptoms are the same, treatment the same. You're still going to do fluids, insulin. You're still monitoring for that hypoglycemia, dehydration. They're just not as acidotic because they have a little bit of insulin to help with that. All right, hypoglycemia. What are you going to do if you have someone with hypoglycemia and they're still alert?
Treat them orally with 15 grams of sugar or anything like that.
Yeah, orally, some sugar, try to get that in. What happens if they become unresponsive? How would you treat hypoglycemia?
Dextrose, IV dextrose, 50%.
Yes, or
Glucagon.
glucagon, yep. What are your signs and symptoms for hypoglycemia?
Ooh, clammy skin, tired, irritable.
If you think of that tired mnemonic, each of those, the tachycardia, irritable, very good. Let's see, your insulins. What's the only insulin that can be given IV?
Regular insulin.
Regular, and what's most often used in your subcutaneous pumps, infusions?
Still rapid.
Rapid. And then know that chart, with the peak onset duration for all the insulins. Let's see, if you're going to mix insulin, which are you going to mix first? What are you going to draw up first?
Clear, cloudy.
Cloudy, then
Clear
clear.
Clear to cloudy. All right, any questions so far? with diabetes.
With diabetic ketoacidosis, wouldn't it be hyperkalemia, not hypokalemia?
It's going to, usually it starts off hypo. They can end up with hyper. It's going to depend on their hydration status. Most often these patients are going to be dehydrated and their potassium is going to be low to start with.
Okay.
So that's most often how it goes. Occasionally you can have the high potassium, but then their hydration status, they would not be as dehydrated. So usually it starts off in the low state first.
Okay.
Good question.
Just one more question. When you said they're going to have the low blood pressure, is that for DKA?
Yes.
Okay.
Yeah, it usually starts with, it's usually a patient who has been sick. There's some kind of illness, some kind of stressor that's going on. And then it just kind of then spirals, and it can spiral kind of quickly with that dehydration. All right, so today we are going to get into thyroid. And then Wednesday we'll finish up with obesity. And so I encourage you guys to use all of those supplementary tools that I've given you. Has anybody been on to do the Swift River case study for there was one with a diabetic patient?
Yes.
Was it good? What did you think about it?
Well, I think that sometimes when they ask you to the things you do first, it's kind of confusing. So you have to really maybe do it 2 times or something like that before you get a hint of it. Because sometimes when I feel like you need to do some things before telling the doctor or something like that, it says you need to notify the doctor. So cases like that. And when it came to medication, that was when I was asking the medications that you have to give, you need a second witness before the insulin that, yes. So I think it's good. I mean,
good. And it sounds like it's helping to apply it too. So that's good. Apply and prioritize too. So that's good. Very good. All right, I'm going to try to record this again as well, and then I'm going to share my screen. Okay. All right, is everybody able to see this first slide? It just says thyroid on it.
Yeah.
Okay, very good. All right, so with the thyroid, you're basically, when you're thinking of the thyroid, so your hyperthyroidism, I think the best way to think of it is hypermetabolism. So think of everything with that metabolism being sped up. Everything's quick and it's all sped up in that process. With your hyperthyroidism, there's excessive thyroid hormone secretion from the thyroid gland. The term thyrotoxicosis is a term that describes, it's just saying that there's high thyroid hormone. Whether it's caused by hyperthyroidism or not, it could be caused by taking too much synthetic hormone. But just the term thyrotoxicosis just means that there's a high state of thyroid hormone, if you hear that term. So again, think of high metabolism. So it causes an increase in metabolism in all of the organs. This can be short-term or permanent. So it can be short-term in the sense that if you're taking too much of the medication, or it can be permanent, maybe there's some kind of damage long-term that has happened. So the most common cause is an autoimmune disorder that results in what's called Hashimoto's thyroiditis, or they abbreviate that HT. It's also called Graves' disease. So that's probably the most common one for hyperthyroid. Some of the signs and symptoms of this are exclusive to Graves' disease. So when I'm saying the Graves' disease, it's the autoimmune disorder that has caused this increase in production of the thyroid hormone. So in this, and you'll see this on some of the next slides, you'll see what they call exophthalmos, which is an abnormal protrusion of the eyes. So now when you're out in public, after I show you these slides, there may be somebody out in public that you walk up to and you're like, oh my goodness, I wonder if they have Graves' disease. And I'll show you this picture in just a minute. There's another term called pretibial myxedema. And this is it's a dry, kind of waxy swelling of the front surfaces of the lower legs that kind of looks like tumors or what they call keloids. Again, I'll show you a picture of that. Not all patients with a goiter have hyperthyroid. I'm going to show you what a goiter looks like too. So you can, it can be caused by multiple thyroid nodules, or what they call toxic multinodular goiters. So I think it's the next slide that I'll start showing you some pictures of these. So when you have the toxic multinodular goiter, it's milder, the symptoms are milder than Graves' disease, but it's caused, there's like little tumors or this enlarged tissue that gets into the thyroid and causes that excessive production and release of the hormone. So it can also be caused by excessive intake of replacement hormones. So maybe they have hypothyroidism, they're taking the replacement that then could cause hyperthyroidism. So that would be the exogenous hyperthyroidism. So these are kind of the different types and what can cause these different types. So again, most common is Graves' disease, which is autoimmune. Then there can be what they call these goiters or nodules that are in there that can cause it to produce additional hormones, or it can be caused by excessive, too much of the replacement hormones. So these are the eyes, the exophthalmos. So you'll see these big protruding, the eyes just look very protruding from there. This is your normal, if everyone can see this pink, I don't know if y'all can see my mouse that's hovering over that or not. This one on the left is a normal thyroid. And then when you end up with these goiters, it causes this excessive production and it makes it even thicker. To where these pictures up top here, you can see a mild protrusion of the thyroid, and then it kind of gets larger depending on the severity of that. So again, with the eyes, this is specific to Graves' disease. The goiter can be with any type of hyperthyroidism. So then we'll kind of go through different features and different things that happens with each body system with hyperthyroidism. So again, think hyperthyroidism, hypermetabolism. So it's going to impact every body system. So every body system is on kind of hyper speed. So with the skin, you'll end up with diaphoresis. You'll have thinning of the hair. Cardiac, you could have palpitations, chest pain, an increase in their blood pressure, tachycardia. You could have some dysrhythmias, rapid, shallow respirations. So again, fast and high. GI, so everything's fast, so they can't take in enough to keep up with what's going on. So they're gonna have weight loss. They're gonna have an increased appetite. Of course, because of that increase in appetite and increase in their stools. that increased metabolic rate. They're going to be heat intolerant. They can often run a low-grade fever. They'll just be fatigued. They're going to feel like they've run a mile or a marathon. They're just going to be fatigued all the time because their body's just on that high speed again with the metabolism. You can see the eyelids kind of being retracted a little bit. And if this picture kind of shows, so you have the eyelids are kind of back because the eyes are kind of protruded a little bit. And again, that one is specific to Graves' disease. Hyperactive deep tendon reflexes, tremors, insomnia. They can have impaired vision or double vision, blurry vision. Their eyes could be slow to respond, an increase in their tear production, sensitivity to light, and then that protrusion of the eyes, again, specific to Graves' disease. So psychosocial and emotional, they'll have a decreased attention span. They'll have some restlessness, irritability, emotional lability, manic behavior. With the reproductive, if it's a female, they may not have their menstrual cycle. They could have an increase in their libido. And then just some other manifestations. So they could have the goiter in the neck. So that's the excessive to the thyroid gland. They can have that wide-eyed, kind of startled appearance. The spleen could be enlarged. And then muscle weakness and muscle wasting. So this is a good slide to show kind of that summary of this. And so when it says about the, go back real quick. Yeah, the term here, the pretibial myxedema, that is also what you'll see here with this. You'll see the swelling at the front of the legs. That's the pretibial myxedema. So they're going to be thin and have weight loss, but then their legs are going to look very, very different, and maybe even some edema, and it's going to have that waxy appearance to it. So again, hyperthyroid, hypermetabolism, everything's fast, intolerance to heat, tachycardia, weight loss. They just can't keep up, like their body just can't keep up with how quickly everything is going on. These are, so what are you going to look for? What are you going to look at with a patient with hyperthyroidism? So these are the different labs. I'm going to go over what these lab results will be in just a moment. So you'll be looking at your T3, T4, and TSH. And then the TRABS is specific for Graves' disease testing. And then some of the diagnostic, you'll do the thyroid scan, ultrasound, and then you want to monitor their heart. You'll also want to look at their heart and EKG for any changes, any arrhythmias, or changes with their cardiac function there. All right, so this is a slide graph that you will want to know from here on out till you take your NCLEX. So for me, what I highlight is your serum T3, your T4, so whether it's your serum or your free T4, these are going to be the same in hyper or hypothyroidism. And then at the bottom, your TSH. And so what I want you to pay attention to, so like with hyperthyroidism, your T3, T4 are going to be elevated, and your TSH is going to be low in the primary disease. So it's going to be high in secondary disease. We're not going to focus on secondary disease. We're going to focus on primary disease. So this first line here. So if you have an increased T3, T4, and a low TSH, then you have hyperthyroidism. And then the opposite for hypo, if you have a decreased T3, T4, and a high TSH, then you're going to have hypothyroidism. Does that make sense?
No, I mean, it does, but I need you to say it again.
Okay, sure. So for hyperthyroid, your T3 and T4 are going to be elevated. And then your TSH is going to be low. So we're focused on primary disease. We're not going to focus on secondary diseases. So we're focused on primary. So for hypothyroid, your T3, T4 are going to be decreased and your TSH is going to be high. So I would like highlight under TSH, I would highlight low in Graves' disease, and then under hyperthyroidism and under hypothyroidism, I would highlight that it's high in primary disease. So don't focus on that second line where it's the secondary disease, because I don't want it to confuse anybody. Okay, so some interventions for hyperthyroidism. So you want to decrease the effect of the thyroid hormone on the cardiac function, because that's the function that you're going to be the most worried about, is how is the thyroid impacting the heart. So your goal is going to be to decrease the thyroid hormone secretion, certainly keep them comfortable, reduce some of that stimulation because they're already feeling pretty overstimulated. A lot of teaching, and then teaching for the medications. In these patients, you're going to want a high carbohydrate, high protein diet because that metabolic rate is so fast. And then you're going to monitor for complications. So that could be with their respiratory, it can be chest pain, vertigo, palpitations, temperature and blood pressure. Those are all areas that you're going to monitor pretty close. And with a patient with hyperthyroidism, if you have a patient who's starting to run a fever and that fever starts to climb and their blood pressure starts to climb, those two things together, so if they're running 101 fever and it goes to 102 and their blood pressure elevates slightly, those two things, temperature, blood pressure, elevate even by small increments, that should send off a red flag to you. And you'll want to start watching for what they call thyroid storm. And we're going to talk about that a little more too. All right, so medications to treat hyperthyroidism, your thionamides, your iodine and iodine-containing agents, and then beta-adrenergic blocking agents. So your thionamides, this is kind of your daily treatment. These are medications they would take to prevent more of the thyroid hormone being produced and secreted. To where your iodine and iodine-containing agents, these are more for rapid short-term treatment. Sorry, I think the dogs are about to go crazy. So your iodine and iodine-containing are more for short, quick-term or rapid treatment. Sorry, there's fire trucks going by and the dogs are all going crazy.
Can you repeat that again? You said the better. What was the last thing you said?
So your iodine and iodine-containing agents, those are more for short, like quick treatment. So if you had a patient with thyroid storm that you wanted to treat quickly, your iodine and iodine-containing agents are that quick, rapid, short-term treatment, to where your thionamides are more the longer-term treatment. Let me close this door. Hold on. Okay, sorry. So did that help? So again, your thionamides, longer term treatment for like your daily treatment, and then your iodine or iodine containing kind of that short, quick treatment. So used when you have a patient that you're suspecting thyroid storm or severe hyperthyroidism, that you want to get it under, you want to get it down kind of quick and treat it quick, and then your thionamides would be used for kind of that long-term treatment. Does that make sense?
Yes.
Okay.
Yes, it does. Is
Okay.
the blocking drugs, the propranolol, is that a short or long term?
That would be a short term as well.
Thank you.
And so with any of these, you're going to monitor for hypothyroidism. So if you have your patient that, is taking, their daily medications, and then they're starting to have symptoms of hypothyroidism, that's when you're going to check their levels, because maybe you need to back off of the medications and make some adjustments of that. And we'll talk about that a little bit more too. Okay, so this is kind of a summary of your medications for hyperthyroidism, and then some of your dosing and nursing interventions and rationale. So some things that you want to teach and know with your patients. So this is, I would recommend this graph chart, however you want to call it. This would be a good one to know. I could see some really great NCLEX questions coming off of here that you would need to know. Like, I mean, they're not going to ask, but for example, you would need to know that this medication can cause liver toxicity. So your PTU, you would want to teach for signs and symptoms of liver failure. We're gonna get into the signs and symptoms of hypothyroidism, so you would want to teach them those signs as well. If they're taking your topazole, the methamozoles, then if you have a female who's pregnant, they need to notify the physician before becoming pregnant, because this medication can cause various birth defects. Sorry, guys. Can y'all still hear me okay?
Yeah.
Okay. Sorry. I don't know why the dogs are barking outside. So for any of the hyperthyroid medications, you're going to teach for signs and symptoms of hypothyroidism. And then for your thionamides, you're going to teach signs and symptoms of liver toxicity. If you have a female of childbearing age, you would want to educate them to notify the physician before trying to become pregnant, or as soon as, if they do end up pregnant, notifying the doctor as soon as they are, so that they could find a different medication. And then, let's see, I think it's with the other one. So then with your iodine containing agents, like these can cause that metallic taste in the mouth. So just some things to kind of watch for and prepare for. So again, your iodine containing agents, your quicker treatment, and your thionamides, more of your day-to-day longer term treatment. So your radioactive iodine, so this they can put into the thyroid gland, or well, it will target the thyroid gland and destroy some of those cells by local radiation. So this is a kind of a combination of quick and long-term treatment. So it's injected, targets the thyroid gland, but then can take several weeks for you to see the result of it. So they're basically putting in the radioactive material, radiation. And then it will destroy some of those thyroid cells to then decrease the production. So in this, so if you have a patient that is getting the radioactive iodine, you would want to teach them, their body fluids are going to contain some radioactive material. They'll do different education to prevent, like precautions to prevent exposure to family members. And then for these patients long-term, you would also monitor for hypothyroidism. In case it destroys many of those cells, then you'd monitor for hypothyroidism. So this would be a treatment they can do to help. It basically destroys some of those cells, which then decreases the production and secretion. So then there's also surgery that can remove part of or all of the thyroid gland. Surgery is usually the preferred treatment for Graves' disease. They may have the goiter that they may have to remove. Sometimes if that goiter really grows, in those pictures that you saw, that goiter goes outward, but think that goiter can also grow to the inside as well. So it may cause some tracheal or esophageal compression. So hold on one second, guys. Let me see if I can get these dogs to hush. Let's pause for just 1 second. Sorry, guys. See if some dog treats will help real quick. Okay. Okay, so back to surgery. Can you guys hear me?
Mm-hmm.
Okay, making sure I did unmute myself. Okay, so surgery. So removal of all of or part of the thyroid gland. So that is the preferred treatment for Graves' disease. Again, they may have to remove, at some point they may need surgery just to remove the goiter if it's causing any compression to the trachea or esophagus. Your total thyroidectomy would be the complete removal of the thyroid gland. And your subtotal thyroidectomy is the partial removal of it. So certainly pre-operatively, you'll have them continue taking their medications. They will take the iodine to decrease the risk of thyroid storm, because there's times where if you push on that goiter, it can cause this big release of hormone. And so if they're in there manipulating that goiter, then you could end up with a thyroid storm. So they try to be proactive with that and use the iodine to help decrease the risk of the thyroid storm. Preoperative, you'll teach them that you're going to monitor for hemorrhage, manage their symptoms, and then you're going to teach them deep breathing and coughing exercises to support that incision. So the incision will be up in the neck, and so they can use a pillow, something to help support that incision, but you'll want them to continue to cough and deep breathe to prevent any pneumonia and take care of the lungs too. But then how do they support that incision? So post-operatively, monitoring for complications. And in this, so you're gonna certainly monitoring for hemorrhage and any bleeding. You'll monitor for any damage to the parathyroid gland. So if there's any damage to the parathyroid gland, you would have hypocalcemia and the tetany, so signs of the hypocalcemia. There could be some damage to the laryngeal nerves, so they may be hoarse or have a weak voice. They could have thyroid storm, because again, managing that goiter, if there's any mashing on that goiter, as you're taking that out, then there could be this big release of thyroid hormone that could then cause the thyroid storm. So again, your thyroid storm, you're going to watch for the blood pressure and temperature going up. You'll focus on pain management. They'll usually do the semi-Fowler's position. And then the biggest thing that you're going to watch for is respiratory distress. So if you have a patient with Stridor, that is an emergency post-op thyroidectomy. So Stridor post-op respiratory distress, that becomes an emergency to treat with their respiratory system. And steroids can be used to decrease that swelling. I think we're gonna talk about this a little bit more. So, so with your thyroid storm or thyroid crisis, you'll hear both terms. You're going to monitor for this post-op as well. So the temperature and blood pressure continue to go up. So it's most common with your Graves' disease patients, so your autoimmune patients. Triggered by stress, so trauma infection. If you also have a diabetic patient, you'd want to certainly monitor. So say they're diabetic and hyperthyroid. So this could also trigger a diabetic ketoacidosis response after surgery. If they're pregnant, or if you have a patient with a large goiter, you want to be sure just on your, set aside surgery for a moment, even on your regular assessment, you don't want to mash on or manipulate that goiter too much. You don't want to palpate that goiter too much, because if you're in there mashing on it all the time, you could cause an excessive release of hormones too. So again, your key kind of symptoms you're going to look for post-op are fever, tachycardia, and hypertension. And then if you have that patient post-op that has that hypertension, increased temperature, and you're suspecting thyroid storm, the first and foremost, you're going to maintain their airway. And then you'll use your various medications, so your anti-thyroid medications. You could use your daily ones, but then they're probably going to get the iodine to help get it down quickly. Your propranolol will help with comfort during that time period. Some steroids to help decrease any swelling. And then you'll monitor for any cardiac arrhythmias or dysrhythmias. and then make sure they're dehydrated. And then you may need some cooling blankets too. So this would be after surgery. So again, first and foremost, you're gonna maintain their airway. And then medications to treat and to bring those levels down. Swelling, monitoring cardiac effects, and then fluids and comfort and keeping them cool. So then this just has some nursing diagnosis that can be used with hyperthyroidism. And then this again just highlighting that if you have a patient with severe hyperthyroidism and you notice that their temperature is climbing, you're also going to check their blood pressure. Their blood pressure is probably climbing as well. Then that would alert you to get somebody in to start responding. So I'm going to back up just a minute. So the other thing with these patients with your thyroid storm, post-op, so you have your so backing up just a minute. So surgery for hyperthyroidism to remove part of or all of the thyroid gland. So again, you're going to monitor for hypocalcemia because of damage to the parathyroid gland. You're going to monitor for stridor and swelling. And so if you have one of these, what are you going to need to treat these? What would you need to treat if there was damage to the parathyroid, you have some hypocalcemia, and you're starting to have all of the symptoms that are going along with hypocalcemia?
Give them calcium.
Correct. You're going to give them calcium. Perfect. That's so you're going to have calcium close by for your post-operative patients after that either partial or complete removal. So then if you have a patient in respiratory distress, they're having stridor, and they're having stridor because of the swelling and edema, how do you think they would manage that airway? Intubation. Okay, so you go in, the respiratory therapist or CRNA, whoever comes to do the intubation is there to intubate, and they're having a really hard time because of all the swelling. What do you suspect they may have to do emergently?
Give them steroids.
You're going to give them a trach.
Steroids is not a bad answer, but first you've got to get to the airway. So whoever said the trach.
Okay.
So post-operatively, you're going to want close by, somewhere close by, you're going to want everything to do an emergency trach, and you're going to want some calcium fairly close by. At least know where those are so that if you do have a patient that gets into this respiratory distress pretty quickly and there's a lot of swelling, if they can't intubate, they'll need the trach emergently. And then the other complication, if you have the parathyroid damage and they're having the hypocalcemia, certainly you'll check that, monitor their signs and symptoms, but then calcium to treat. So those are the two things that you're gonna want to make sure you have fairly close by, just to be sure. You know, they may do fine and they may not have any of these symptoms, and they might just breeze right through. But if they do have complications, those are kind of the two biggest that you're going to look for: the respiratory and the hypocalcemia and thyroid storm. So the three, I'm sorry. So then thyroid storm treatment, you're going to do fluids, medications to get the thyroid hormone down, and then keep them comfortable in the meantime as well. Does that make sense?
Yes.
All right, questions on hyperthyroidism for now. Let's stop sharing for just a minute.
Bring the blood pressure down.
Say that one more time.
It's as in IV normal saline to bring the blood pressure down.
Mm-hmm. Yes. Any other questions so far? All right, you want to take about a couple minute break and come, how about we come back at 11? I have 10:53 right now. So how about we come back at 11 and then we'll do hypothyroidism.
Okay.
Sound good?
have a question, Ms. King.
Yes.
Okay, so for the nutrition, you want us to give the high carb, high protein. Is that to bring down the metabolism because they're going to have an increased metabolism rate in hyperthyroid?
So hopefully just to help keep up with their nutritional needs, because they do have that high rate.
Okay, so the high carb and high protein will kind of level it out or bring it down. Okay.
Well, it won't bring down the metabolism rate, but
Right.
but they're going to need that kind of diet in order to keep up because it's just using it so fast and it's breaking it down everything so fast.
Okay. Thank you.
Mm-hmm. All right. I think we can go ahead and get started again. I've gotten a few messages asking about Blackboard. I haven't been into Blackboard in the last little bit, but I did get a message from the school that the internet is out on all of the campuses.
Yeah, it's out. I'm trying to get on there now, and it will not. I've tried on 2 separate computers.
Yeah, I know the internet's out, so I don't know how all. I don't know what all that impacts. So I'll reach out to Miss Walker and let her know that. So I assume that until the internet's back up, I assume Blackboard will probably be out as well. Yeah, it says to check the email, but I don't have an email. Does anybody have an email that goes into detail about it? No. I'll say I have a text message that says check my email, but I don't have anything in my email yet. And so that's what yeah, if their whole internet system's down, I don't see how they can send an email. So so I'll reach out to Miss Walker. If it's fixed here in the next little bit, then if you haven't uploaded all of your clinical paperwork, I'll have Miss Walker send something out. I'm sure she'll have to extend that if you can't do it. So I'll reach out to Miss Walker. All right, any questions on hyperthyroid?
Ms. Fink sent an email to our emails.
Yeah, but
that email didn't have anything to do with this.
Yeah.
Yeah, so I don't see any emails from the school since after about 9:45. So all right, so we will start into hypothyroidism. And so before we go into this, just a quick reminder. So once you're able to get back into Blackboard, on Blackboard, I posted some case studies that you guys can use to help. Those will help you to study and help you apply some of the information too. So there's case studies and then your Swift River patients too. So all of that will help you with the material too. Okay, so hypothyroidism, think hypometabolism. Everything is slow. So kind of certainly the opposite of hyperthyroid and everything being fast with metabolism. Now everything's going to be slow. So pathophysiology-wise, you're going to have a decreased metabolism because of low thyroid levels. So for whatever reason, the thyroid cells are not producing the hormone. In some areas, usually not in the US, but in some areas, the patient's not ingesting enough to make thyroid hormone. So this would be some of your other countries where they're just, the malnutrition is so bad that they're not ingesting enough for the body to then make the thyroid hormone. Usually in the United States, it's that the cells are not producing enough thyroid hormone for whatever reason. So some of your causes could be the hypothalamus and the anterior pituitary. That's what produces your thyroid stimulating hormone. Or is not producing enough. So this can also cause a goiter. So your goiter is not specific to hyper or hypothyroidism. You can have this goiter and this abnormal formation in the neck for both of them. So in that hypothyroidism, all of the cells have that decreased metabolism. And then you get this buildup in all of the body cells of mucus and water, causing edema in the cells, which is called myxedema. So this is different than what we talked about earlier. Sorry, with hyperthyroidism. With hyperthyroidism, remember we talked about the swelling just in the legs. So that was specific to the legs. This, we're talking about every single cell in the body has a decreased metabolism. And then you get this buildup of mucus and water in the cells. And so you have edema, which is myxedema. So that term myxedema is just the edema. And you're going to have this in all of the cells throughout the body. So myxedema coma is a rare, untreated, sorry guys, these dogs are going crazy today. Hold on 1 second. Sorry, it's our weekly visit from the garbage truck. I'm sorry, guys. I tried putting them in another room and now they're just barking at the garbage truck. Okay, let's try this again. Okay, so with your hypothyroidism, so I just mentioned you can have the edema in all of the cells. So then myxedema coma. So this is a complication from hypothyroidism. So this is when all of this is when you have the excess mucus and water, so that edema or myxedema, but it then occurs in the heart. So your heart is a muscle, so it could be in those cells as well. And so it's when you have the untreated hypothyroidism and that edema continues, and then that edema is in the heart. So then the heart becomes flabby. This is your medical emergency for your hypothyroidism patient. Once it gets to this point with the heart, the mortality rate is very, very high. So treatment that you would use for this would be IV fluids, levothyroxine, we'll talk about levothyroxine in a minute, and steroids. So this is a very rare complication, but it could be from if you have a patient who hasn't been diagnosed with hypothyroidism, so they haven't received treatment for hypothyroidism, and then by the time they're diagnosed, this swelling or edema that is the buildup of the mucus and water is in all of the cells, but then it's focused primarily in the heart muscle. So think if you have the heart muscle and you have this edema in the heart muscle, it's extra fluid, extra mucus, and all of the cells with the heart, then it just can't pump effectively. So then that's when your treatment, IV fluids, the levothyroxine, and steroids. Not a common complication, but something to be aware of if you have a patient untreated for a long time. All right, so hypothyroidism. So most cases are a result of thyroid surgery. So most cases of hypothyroidism, it's a person who started off with hyperthyroidism, then they had surgery and that gland was taken out, and now you've caused hypothyroidism because you've removed it. Or they received the radioactive treatment and it worked really well and it took care of all of those cells. And so now you have a patient with hypothyroidism. So again, in some countries where the soil and water are not as well, so a lot of your very malnourished areas could be autoimmune, could be a congenital, so you have a baby that's just born with that. It didn't develop for whatever reason. There's damage to it. Could be caused by cancer. Your hypothyroidism is more common in women than men. I'm not really sure why, but it is. And then when diagnosing, you'll assess for any medications that have caused the hypothyroidism. So features, so we'll go through each body system just like we did in hyperthyroidism. So your skin with your hypothyroidism is going to be cool and dry, kind of pale. It may have a yellowish tint to it. You'll have thick, brittle nails, dry, coarse, brittle hair. Some of these patients lose kind of their eyebrows. They don't have good wound healing when it comes to their skin. Pulmonary wise, you'll see hypoventilation. They may have pleural effusions and some difficulty breathing. And so that could be somewhat related to the just the extra fluid in there and everything's being slow. So just think everything's so slow, it's not cycling like it should be. Cardiac, these patients may report some chest pain. So again, hypothyroid, hypometabolism, everything's going to be slow. So their heart rate's going to be slower. They could have an enlarged heart. They'll have a decreased in activity intolerance, usually some hypotension. That metabolic rate is slow. They'll have a decreased body temperature. They'll be cold intolerant. They're going to be sleepy. Psychological, kind of flat affect a little bit, the apathy, depressed. They could have some paranoia going on. GI wise, they're going to have weight gain, but they're not going to be eating a lot usually. Some constipation, again, everything's just slow to move through. Maybe some abdominal distension too. Neuro-wise, some of these patients have slowed speech, and it can even impact their memory. Again, everything's slow, so they're going to be lethargic. They can have some confusion, some hearing loss, muscle aches and pains, decreased in their reflexes. For reproductive, for men and women, you'll have the decreased libido. For men, this could cause some impotence. For women, that menstrual cycle could just stop, or there could be some changes in that. And then these are some additional features. So they'll have the periorbital edema. So around their eyes, some of that edema, facial puffiness. There's a good picture, I think it's on the next slide, that shows some of this. The non-pitting edema. So again, this is where they have the extra mucus and water collecting in all of the cells. And so they'll have that extra edema throughout. They could be hoarse. They could also have a goiter. Remember that goiter is not specific to hyper or hypothyroid. They can have a thick tongue, and that, so think of edema in their tongue as well. These patients could be sensitive to opioids. So the metabolism's slow, so it's not breaking it down as well. So you would start really low with any opioids that you needed to give these patients. They'll be weak, fatigued very, very easily. They'll bruise easy, and usually they'll have a lot of iron and vitamin deficiencies because the body's just not breaking down things and it's not going where it needs to go. It's doing it, but it's doing it very, very slow. So this one, if you were to compare the hyperthyroidism and the hypothyroidism slides and the different symptoms and what you'll see with all of the organ systems. So remember, hypothyroid, the intolerance to cold, kind of that blank expression on their face. They'll have generalized edema to where you're hyperthyroid. Remember, that's just going to be in that front of the legs that you're going to see that edema. Let's see, constipation, everything's just going slow. Fatigued, dry skin, facial eyelid edema, so kind of all of those. And then some of those later clinical manifestations, you'll see the bradycardia, some weight gain. And then if you see the cardiac complications, that is from the myxedema going into the heart muscle. And then that's when you want to be really careful and treat that aggressively as well if they do end up with that complication. So again, your labs, this is the same slide as before. So your hypothyroidism, your T3, T4 are going to be decreased, and your TSH is going to be high. Again, we're just focused on primary disease for the TSH, not the secondary disease. So some interventions for hypothyroidism. So you're going to try to improve their gas exchange. So you're going to monitor oxygen levels, monitor for any cyanosis, keep an eye on their cognition levels. Are they confused? And then you want to be really careful with any opioids and not to oversedate them. Again, that metabolism's slow, so it's taking a long time to break it down. So you want to prevent hypotension and report any chest pain they have immediately. And then supporting their cognition. So some of them, if they are really lethargic, they may have a poor attention span. Now, if it's all managed well, these symptoms, all of these symptoms may be very, very mild. So it'll just depend on how they're managing too. Then your myxedema coma. Remember, this is when it impacts the heart and focuses on the heart. So you have that edema in the heart muscle. Your goal is to prevent that. So the earlier they can be diagnosed, the better treatment and control. So the goal is to get that treated as quick as possible. So your risk factors for myxedema coma would be a patient newly diagnosed, somebody after surgery or an acute illness. Maybe they have cancer and they're going through chemotherapy. They've stopped their thyroid replacement or use of sedatives and opioids. So any of these patients, when you start having those symptoms with the myxedema coma, making sure you're treated. So respiratory failure, you'll see hypotension, hyponatremia, hypothermia, hypoglycemia. So you'll kind of see all of those in combination with it. Again, not common, but just something that you need to be aware and on the lookout for. So treatment in general for hypothyroidism. So your treatment is going to require lifelong thyroid hormone replacement. Your most common is your levothyroxine or Synthroid. That's your most common replacement. They usually start low with that, and then we'll monitor the levels over a period of time and then make the adjustments. They start low as you don't want to start too high so that you're impacting the heart. So again, starting low, then they'll monitor those lab levels and make adjustments as they need. So when you're taking the thyroid hormone replacement, teaching for these medications is you don't want to change the dose or the brand yourself, or like the patient to do it themselves. So this, they'll want to definitely make sure they're speaking to the physician before making any of those changes. If they go to the pharmacy and the pharmacy, says, this supplier is running low, so we have it from this supplier or this brand. Check in with the physician, because they may have them come in, if that's all they can get, they may have them come in for an extra lab level to keep a close eye on that. So just anytime there's any changes, making sure they're speaking with the physician. And then your patients with hypothyroidism, you're going to teach signs and symptoms of hyperthyroidism. You're also going to teach them signs and symptoms of hypo, but when they're taking the thyroid replacement, you want them to monitor those signs and symptoms of hyper to know if the treatment is too much, and they need to come in and have those levels checked. With these patients, nutrition, simply a well-balanced diet. And a lot of times they'll avoid fiber supplements with these patients because it can interfere with the absorption of their medications. These, they also take on an empty stomach. I think it's like 30 minutes. I think it's like 30 minutes before a meal to take these. So it can be absorbed the best. So think, does anybody want to guess why? Why would you think you would take this on an empty stomach?
So that when you eat, you can absorb the most nutrients from your food?
Say that one more time.
So that when you're going to eat, maybe you could absorb the most nutrients from your food?
Think before you take in the food. Why would you think a little before that? Not a bad answer, but think a little before that. Why would you want this patient to take these medications on an empty stomach?
So you're going to absorb the medication.
Right, because their absorption and everything's so slow already that the best chance, you want them to absorb the medication before the food. And so that way they're taking the medication on an empty stomach. So hopefully as much of the medication will absorb first, and then the nutrients from your food then afterward. So So these are some potential nursing diagnoses that can be used with hypothyroidism. So impaired gas exchange, hypotension, altered cognitive functioning, and then monitoring for any potential for the myxedema coma. So certainly, as with many of our diseases that we're learning about, you want to prevent complications and have the most optimal health as possible. Any questions on hypothyroid? Stop sharing and pause for just a minute there. All right, what's everybody thinking about hypothyroidism? So low and slow, everything's slow. I think let me hit share again. I think this slide. I think this slide this slide for both your hypo and hyperthyroidism does it's a good summary slide. So when you're looking at your hypothyroid, the intolerance to cold, that generalized edema, the thick tongue, constipation, so everything with the gut slow, bradycardia, weight gain. And then if you compare this to your hyperthyroid, remember that your edema and your hyperthyroid is going to be just localized to the legs. These patients are going to have weight loss. Your goiter could be with either one. Your bulging eyes, remember, specific to the autoimmune Graves' disease. Intolerance to heat, irritability, tachycardia, increased blood pressure, finger clubbing, tremors, diarrhea, so everything's kind of going through much quicker. And then your treatment would be the thyroid replacement. What questions on thyroid, hyper and hypothyroidism? All right, is everybody good so far with those? All right, I don't see any questions. I see a couple thumbs up, so that's good. Okay, so just a few more things to cover. Whoops. Thyroid. Okay, so just a few more things with the thyroid. So thyroiditis is just an inflammation of the thyroid gland. So you can have an acute, a subacute, or a chronic. So your chronic inflammation of the thyroid gland would be like your Hashimoto's disease, which is the autoimmune triggered by bacteria, something like that. So this, you end up with the Graves' disease. So some of these can have longer impacts, but your acute, subacute, this could be after a cold, an illness, and so some mild treatment, and after that cold or illness, whatever it is that goes away, then everything is better. So whether it's quick or the long-term chronic. So then your long-term chronic, this is when you end up with the Graves' disease, so your hyperthyroid. So cancers, just so for this, just know there's different types of cancers. Some of these are faster spreading than others, and then your kind of your hallmark lab that is checked for thyroid cancer. It's the TG level, this thyroglobulin level. So if that's elevated, then that can be indicative of a thyroid cancer. So that's a lab that they'll be looking at if they suspect some kind of cancer. Or if they're checking your thyroid levels, then they may check this just to be sure. And if it's not elevated, then there's nothing else to be alarmed of. If it is elevated, then they'll start looking further. So your 4 different types, your papillary is the most common. It's pretty slow growing and it could be there for several years before kind of knowing where it is. It's usually confined to the thyroid gland. So usually once they go in, they can remove it, and usually cure is pretty good with your papillary type. Then there's the follicular. And this is most often in your older patients. And this one can spread and invade blood vessels. It can go into the bone and lung tissue. It can adhere to the trachea and some of the muscles in there. And this one can also involve the laryngeal nerve. And the medullary is common in patients over 50. Occurs as part of a multiple endocrine neoplasia. So short for that, MIN is the short for that, multiple endocrine neoplasia type 2. Secretes calcitonin and hormones and prostaglandins and serotonin. So you have a lot more implications with that one. And then your anaplastic is very rapid. This is a very aggressive one that can then cause stride or hoarseness with that. So for these, I'm not focused on the 4 different types. Just know for my purpose, there's some that are quicker growing than others. For me, I want you to know the lab level and then some of the treatment. So like your treatment could be the total or subtotal thyroidectomy. So what would you do with that? We've already talked about that with hyperthyroidism. And then post-op, you're going to teach them to monitor for hypothyroidism. So there's a lot that overlaps with treatment of thyroid cancer with your hyper and hypothyroidism. All right, and then we're going to touch on parathyroid. So your parathyroid gland maintains your calcium and phosphate balance. If you have an increase in your levels of parathyroid hormone, it causes the kidney to reabsorb the calcium and excrete the phosphate. And so, so here with hyperparathyroid, you'll have hypercalcemia and hypophosphate. And then if you have hypoparathyroid, you'll have the hypocalcemia. And oftentimes your phosphate's high. Make sure I was saying that right before I said it. So basically you're going to look for electrolyte imbalances, treat those, and then treat that underlying cause with that. So that's just kind of high level on parathyroid. Just know it controls your calcium and phosphate and the reabsorption or excretion of those. And that is all I have for thyroid. What questions do you guys have for thyroid? All right, so let's see what, all right, so tell me some signs and symptoms of hyperthyroidism.
Did you say hyper or hypo?
Hyper. So what would you see in a patient with hyperthyroidism?
Weight loss. bulging eyes,
Goiter.
Mm-hmm. Weight loss, bulging eyes. Yep. Tachycardia, the goiter.
Dry skin.
What'd you say about the skin?
Dry skin.
Mm-hmm.
Could be yellowish skin or something. Yeah.
Could. What would you see? What's kind of classic for this one with the legs?
Tibial
edema.
Yes, the tibial edema. Yes, very good. So what about signs and like what would you see in your patient with hypothyroidism?
Overall edema.
Yep, overall edema.
They can't tolerate the cold.
Right.
Constipation.
Yes, constipation. Everything in the gut is slow. Tachycardia or bradycardia?
Bradycardia.
Bradycardia, weight loss or weight gain?
Gain.
Weight gain. Mm-hmm. And then what complication are you going to monitor for in someone that you're just diagnosing with hypothyroidism? What complication are you going to keep an eye out for?
Diabetes. If they're diabetic.
You will want to know that.
Elevated temperature and elevated, what is it called? I can't remember.
So I know where you're going. You're thinking the elevated temperature and elevated blood pressure.
Yes.
So that would be the complication for hyperthyroidism.
Hyper?
That would be the thyroid storm that you're watching for with that. So it's good you remembered, but you're thinking, so the thyroid storm would be with that. What cardiac complication are you looking for with hypothyroid though?
A flabby heart.
Yes, the flabby heart. So that comes from that, remember that generalized edema that goes to every cell. You have that extra water and mucus. And if that edema goes to the heart, yes, you get that flabby heart and the heart's not functioning as well. And so that would be, that's the myxedema coma that you're looking for. That's the flabby heart. And then you would do IV fluids, steroids, and then your levothyroxine. To where your thyroid storm could be after surgery, after they've taken out that, or it could be something that has caused either some manipulation of that goiter, something that's caused a quick release of a lot of that, the hormone. So your thyroid storm, I don't remember who said it earlier, but yes, you're watching for the elevated temperature and blood pressure. And these patients, you're going to maintain their airway. You could do the iodine for a quick treatment to try to get that that level down, and then your propranolol for symptom control, and then some steroids, and then continuing to monitor the heart.
Miss King, I have a question.
Mm-hmm.
The labs on the PowerPoint for thyroid isn't showing up. I don't know if it's just mine or what, but like all the words are cut off.
Is that the case on both? So it's slide 14 and slide 31. Wait, is it 14?
Just it's slides 11 and 14.
I'm sorry, not 14. Slide 11 has the labs. So are words cut off on that one?
Yeah, like the slide that says labs,
Mm-hmm.
like the TS4 and 3, like all the words are like cut off. And I can't see it.
Does anybody else having? Is anybody else having that problem?
Mine not here though. No.
Do you see it on slide 31? Because that's the same slide.
No, I don't.
Is that Alicia?
Yes.
Is there anybody else that's having that problem? All right, Alicia, I'm going to try to email it to you and see if that's any better. See if maybe there's something in that download or something. And since you can't get on Blackboard right now anyway, I'll email it to you when we're done here.
Okay, thank you.
You're welcome. All right, so let's see. Okay, so post-op complications after a thyroidectomy. What are you gonna monitor for?
Bleeding.
Bleeding? What else?
Swelling airway.
Someone said airway. What else?
Hemorrhage.
Mhm.
Low calcium levels.
Yes, low calcium. And so what does a low calcium indicate?
Parathyroid gland injury.
Right, there's some injury, right, to the other gland, your parathyroid. So yes, so low calcium. So signs and symptoms of hypocalcemia, which you would treat with calcium. And then what's another big complication you're going to watch for that would become an emergency after a thyroidectomy?
Airway.
Stridor. Yes, stridor airway. Very good. And so if they're unable to intubate because of edema, what would you need?
Suction, trach suction.
Right. Stuff to do a tracheostomy if it goes that route. Again, that's not frequent that you have that degree, but if you do have that degree of swelling, odds are they're probably not going to be able to intubate. They would have to do the tracheostomy. Let's see. So you have a patient with hypothyroidism. What are you going to teach them about taking their Synthroid?
Take it without food.
Right, without food, empty stomach before taking it. What else?
Continue or use or change your medications.
Yeah, if you change it, anything changes with it, to call the physician and just talk through it with that.
Don't take any extra fiber supplements.
Right, very good. What about medication teaching for your hyperthyroidism? So with your like your thionamides and PTU medications, what would you teach patients about those?
Thionamides is liver toxicity.
Liver toxicity, very good. And if you have a woman of childbearing age,
to tell the doctor before they get pregnant.
Yes, having those conversations, or as soon as they find out they're pregnant, to reach out.
Also check for weight gain, because it could be a sign of hypothyroidism.
Right. So whether you have your whether you have a patient with hypothyroidism taking medications or with hyperthyroidism taking their medications, you're going to teach them the signs and symptoms of the opposite as well. So if you have a patient with hypothyroid, you're going to teach them signs and symptoms of hyper. And if you have a patient with hyperthyroidism, you're going to teach them signs and symptoms of the hypo, because those medications can cause the other one. So very good. All right, any other questions? So we've covered diabetes and thyroid. So last will be obesity. The obesity is the lightest, I guess you could say, topic that we're going to go over in this unit. So your heavier topics are definitely your diabetes and thyroid. And then, like, if I put in order of importance, I would know diabetes, like your diabetes information first, then your thyroid, and then obesity lastly. So Wednesday, yeah, today's Monday. Wednesday we'll do obesity. And then I know we're going to finish up a little early today. And so what I really encourage everyone to use the case studies that I've posted. I will, well, if Blackboard's not working, I'm not going to be able to email you. Hopefully we'll get Blackboard back up and working today, I hope. But look at the case studies.
The school email is still working.
Is it working?
Yeah. Because I had to have someone from the class send me the PowerPoint because I couldn't pull it off Blackboard. So the email is still working. Blackboard's not.
Well, okay, that's true. Okay, good to know. But I won't be able to access everybody's email address unless I can have access to Blackboard, though, because that's usually how I send you guys an email, is through Blackboard. So that's my only challenge. All right, so if it's going to be longer than today that we're going to have problems with Blackboard, I'll figure out a way to send you guys the PowerPoints and case studies in another manner, but hopefully Blackboard will be back up today. So the case studies that I've posted on there, use those, because those will help you with the information, and they'll help you kind of applying the information too. So feel free to use those case studies that I posted on there. And then the 3 patients in Swift River, I think those will help even apply the information a little bit further. So I think they'll help you like apply the information and then prioritize, like when you have different things going on with these patients too. So I think those will be helpful. So I say all that to say that yes, we're finishing a little early, but please use your time to use those other resources as well. That'll help you out a little bit. And then certainly if you have questions that I haven't answered, call me, text me, email me if your email is working. And then I'm happy to discuss anything that you guys have questions with as well. All right, everybody good so far? I see some thumbs up, so that's good. All right, well, if y'all need me, call me, text me. I will definitely be around, so don't hesitate to reach out, and I'll help however I can. Well, it's good to see everybody, even if it is virtually.
Thank you.
Did you record this lecture?
I did, and I'm going to try to post the audio as well, but I might have to wait till Blackboard's back up to do that.
Okay.
Okay.
Thank you.
All right, y'all have a good afternoon.
Thank you.